Hello and welcome to the next session. The title for the next session is Surgical Training and Continuing Education, a Global Approach to Foot and Ankle Care. And the moderator for this session is Christopher Gross. I see some familiar faces. Shuyan Li has been a familiar face to me, ma'am. Over to you, Christopher. All yours.
Thank you very much. Can you hear me at all? My camera just went out, but you don't need to see me. We all good?
Yes, we can hear you.
Perfect. Good. Okay. Thank you so much. I want to thank Dr. Parekh for inviting me to moderate this session. I'm very excited to share our experience.
Not able to see you.
I understand.
They're not able to listen to you.
Not listen either. All right.
I can hear you.
So everyone can hear me except Dr. Shah. Pire, can you hear me?
I can hear you.
I can hear you.
Okay, perfect. Okay, I don't know what's wrong with my camera, but we'll go on. But anyways, I'm excited to talk with all of you today, kind of a shameless plug for Steps to Walk, and that's great. We're going to talk about surgical training and continuing education, about our journey with working with this organization that has helped countless of lives across the world. We're going to talk about the resident perspective, and we have Jonathon Pire here at the Medical University of South Carolina to talk about his perspective. He's currently on call and is currently running a few rooms in the operating room, so we're going to let him speak first. And then we'll go with Shuyan, who I've met through the organization, and then Dr. Mohammed Saad Ilyas, who is a host for the Steps to Walk organization in Pakistan. So I am very excited for all of you, and I am going to stop talking and let Dr. Pire do his work.
All right, just sharing my screen here. Is everyone able to see the PowerPoint?
Yes.
Okay. All right. Hey, everyone. Thanks for having me. My name is Jonathon Pire, and I'm going to be presenting a resident's perspective on global health and global outreach. I have no disclosures. So for a brief introduction, I'm currently a fifth-year resident at the Medical University of South Carolina in Charleston. I recently participated in the Steps to Walk trip to Manila, Philippines with Dr. Gross in October, and just kind of wanted to share my experience. And then next year, I'm going to Rady Children's Hospital in San Diego for a pediatric orthopedic. So why did I pursue global health, and why do I think others should as well? I think first and foremost, it's the chance to take care of vulnerable and underserved populations, which was one of the reasons I chose to do pediatric orthopedics. Children are the most vulnerable and often have orthopedic conditions that require surgical care. So, it portends well to global health. It's a chance to learn not only from the surgeons that you travel with, but also from the local surgeons, residents, and patient population. It's a chance to teach and share your experience and your training with those in other countries. It's an opportunity to see a place that you do not have otherwise visited. So a quick minute to briefly review the state of global health and surgical training, because I think it identifies the importance and need for surgical care in impoverished countries. Traditionally, global health is thought of as preventative medicine, such as vaccines and infectious disease treatment. But lack of basic surgical care leads to preventable death and disability that often propagates economic inequality. So it's really important. In 2015, the Lancet Commission put forward some statistics basically highlighting the need for surgical care worldwide. 5 billion people do not have access to surgical care, and 6% of the 313 million annual procedures that year occurred in countries that house a third of the world's population. So really 6% of our annual procedures go to 33% of the world. And finally, the lives lost to surgical conditions in 2010 amounted to 16.9 million, which far surpassed HIV/AIDS, TB, and malaria. Focusing more on the resident training perspective from global health, the Yellow Journal put out a review in 2020, survey review, showing that 50% of residency programs offer global health opportunity, which was an increase from 2015 with a similar response rate. Most residents go to Central or South America at 41%, but to a lesser extent go all over the world, including Asia and Africa. And finally, 33% reported sending greater than 10 residents, but 17% reported only sending one. So I think these numbers are actually smaller than they show here, because with the 55% response rate and some programs only sending one, but being considered a global health opportunity, it just suggests that there's room for improvement. So my experience kind of fell along all of those lines. It was a tremendous patient care experience. I got to learn from a great international team of orthopedic surgeons and podiatrists. Got to give a lecture at our initial lecture series on the first day and helped teach local residents in the OR. And finally, explored a city and country that I may not have otherwise seen. This was our schedule for the week. So Monday was that lecture series with the visiting surgeons in the local orthopedic department. Tuesday, we had clinic in a group setting in a conference room where we examined all the patients that were referred from all over the country. Wednesday and Thursday were OR days. And Friday was a debrief where we went over the cases from that week, discussed what went well, what didn't go well, and kind of reviewed the cases from the year before, which was nice because it was almost a follow-up to see how they were doing. So this was the clinic experience. We set up clinic in a conference room with the local residents, attendings, and the visiting surgeons. Patients were referred from all over the country with some very complex problems that required complex solutions. And we worked together to assess each patient and come up with a plan. And once we decided on the plan, we set the schedule for the following 2 OR days. Surgeons took turns assessing patients along with their families. And because we were in a group setting, we had microphones, so we were able to ask questions and share opinions in real time. So it was a great learning experience as well. As I said, the surgeons took turns examining these patients. The majority of the patients were actually pediatric, which was nice for me to see. But it was a great learning experience being in a group setting like that. At the end of the day, we discussed all the plans as a group. So only one of the patients was treated non-operatively. The rest were treated surgically. So we basically discussed our diagnosis and how we were going to treat it, which was great for me as a resident to hear the perspectives of the international team sharing their own opinions and training experience. We discussed what the OR resources were and what we could use to address these problems, and then what the timing was. And then we finally set the schedule for the following 2 days. Wednesday and Thursday were in the OR, and cases were split among the attendings. And then the cases were shared among the visiting and local residents. So we basically divvied up which cases we wanted to scrub into. But even if we didn't scrub into those cases, we were still able to watch them from within the room. And then every single case was filmed live and showed in a conference room across the hospital where the rest of the orthopedic department and local surgeons were there watching. And with microphones and speakers, we were able to discuss with them real-time decision-making in the operating room. So this was our schedule for the second day. One of the reasons I took this picture was because I was impressed with the scrub tech's handwriting, but it just goes to show how much we were able to do, and that was just the second day. Overall, we did 10 cases between the 2 days, but most of those cases had a bunch of different procedures. So oftentimes we were operating on both limbs or operating on multiple parts of the limb, for example, taking out a VDRO plate, but also working on the contralateral ankle. So we did a lot of work in 2 days. It was really fun working as a team. That even though the cases were divvied up among attendings, oftentimes there were multiple attendings scrubbed into the case. So it was really cool to see and learn from them as they were talking intraoperatively about their decision making. And then, as I said, the cases were all filmed and then live streamed in a conference room across the hospital where the rest of the orthopedic department was watching. So it was great, not only to learn from the attendings in the room, but also to help teach those that were in the conference room. And at one point I got bored, so I took over the camera there. So the learning experience is rich anytime you go on these trips. The first day was the lecture series, so we got to hear differing opinions about a variety of different topics, but we also worked through complex cases as an international team. And I think the most important thing that I can't emphasize enough is it teaches you how to adapt with limited resources. I think we get accustomed, especially at an academic center in the US, to using whatever implants or tools are at your fingertips. But in these places, a lot of times you may have one, or you may have to, adapt a different type of implant for a different type of purpose. So it really, I think it makes you a better surgeon because it teaches you how to adapt. This was a lecture series with all the visiting surgeons. We went over a diverse set of foot and ankle topics throughout the course of the day, which generated a lot of great discussion. And it was interesting to hear the differing viewpoints from around the world. As a team, we came up with the surgical plans for these complex cases with input from surgeons from Portugal to Chile to the US. So it was great to hear everyone's opinions. And, I think we're largely shaped by the people that we train under in residency and fellowship. And we often don't get much of an opportunity to hear from surgeons outside of that, except for at conferences. But we don't get that opportunity in a clinical setting for a real patient very often, unless it's on a trip like this. One of the biggest advantages of global health is to learn how to adapt and overcome. Patient problems in these countries are often more complex than they are in the States, with less resources to treat and less access to care. From a patient perspective, we saw, how these patients experience care in these countries. The photo on the right here is the waiting line for the surgical department, and this is in a hot, humid room without AC, and they've been waiting for hours. So it just puts into perspective how patients experience care in this country. And then it also shows you how to make do with limited resources, as I kind of touched on earlier. Teaching has always been a passion of mine. I was a TA through college and medical school, and have really enjoyed my role as a chief resident, kind of teaching the juniors. So it was a nice opportunity to go to a different country and teach residents in that area. The first day I gave a talk on tendon transfers for foot drop, but then in the operating room, I was able to work with and teach the local residents. In this case here, I was helping the junior resident at that hospital take out the VDRO hardware while the rest of the team worked on the contralateral ankle. And then, from a life experience perspective, it's a chance to see a country in a different part of the world that you may not have otherwise seen. And, even if you had plans to go to that country or have visited that country in the first place, these mission trips often take you to a part of it that you would not have otherwise seen. And so it was a great way to experience Manila and see all it had to offer, learn about the local culture and cuisine, and, made new friends in a new place. In our off time, we were able to explore the city. We took a walking tour of the Spanish influenced part of the city, but we also saw BGC, which is the more modern side. So, we really saw both the most impoverished side of the city, but also the most modern part of the city. And it really puts everything into perspective for you. Learned about the local culture and cuisine. As I said, we took a walking tour that included a cuisine tour. So the photo on the right, we were at a local lumpia station, which was delicious, but we also got to see the local monuments and statues. And every night we went together as a big group, going to some of their local favorite places and experience their cuisine. And finally, I really appreciated the relationships we created during this trip. I felt like there was a lot of camaraderie. Every morning we woke up and went to breakfast together, worked in the OR together, and then at the end of the day went out to dinner together. So it was great to work and live with other people taking care of patients. So, in summary, I think a really important aspect of surgical training puts everything into perspective for you. And all the while you're taking care of patients that have very complex problems with very limited resources and who, quite frankly, deserve the best care. So it was a great experience, and I hope that others have the same.
Thank you, Jonathan, for your perspective on that. It sounds like your pages are piling up, and I think you have to run and go answer them. So I appreciate that. And Jonathan was the first resident that I brought on international mission trip. So it was a good learning experience for both of us. And, every year I hope when I do another Steps to Walk, mission trip that we continue the resident or fellow education all the while. I'd like to turn the talk over to Shuyan, talking about delivery of education and humanitarian service. And again, any shameless plugs you want to give, please do.
Thank you very much for the introduction, and it's a great honor to introduce our organization here. Thank you to Dr. Gross, the host, Dr. Parekh, and our host, moderator, Dr. Shah, and everyone. It's good to see everyone. I'm not very familiar with this platform. Just want to confirm, can you see my screen?
Yes, we can.
Oh, all right. Thank you. So I'm going to the screen page. So I'm Shuyan from Steps to Walk. I have the opportunity to help run the Steps to this organization during the past few years, and here I want to share some experience or my experience with you about the delivery of education globally. So here's our mission. We are a nonprofit organization. We mainly travel around the world, treat disabled children and adults, and in the meantime doing education. I will revisit this page later. So here's the
the screen isn't advancing. It just has the first page.
Let me just redo it. Reshare my screen. Okay, let's see if it's advancing now. Can you see it?
It's not. If you want to send me your slide deck, I can do it for you.
Okay. It's difficult. How am I going to send it to you, Chris?
Okay.
Why don't you let's let Dr. Saad talk, and in the meantime I figure this out.
Dr. Saad, regarding educating surgeons through global outreach, would you please give us your perspective if you have your presentation queued up?
Can you hear me?
Yes.
Hello. Yeah. So I'll share my slide with you. Screen. I think I'll have to share the entire screen.
Beautiful.
So is it visible?
Yes.
So thank you, Dr. Gross, for giving me this opportunity. Actually, I'll be talking about educating surgeons through global outreach. And I'll be telling you a story. To signify the importance of this topic, I'm going to start with a small story. Actually, this story begins
in a small town in Pakistan. A young boy with modest circumstances, this drive to do something led him to gain admission in one of the most prestigious medical colleges on a government scholarship. After earning his medical degree, his ambition even grew stronger, and he joined country's leading institutions for orthopedic training. It was a pivotal moment in his journey. There, he was fortunate enough to meet a mentor with a powerful vision that global outreach is essential for achieving the highest standards of surgical training. This mentor tirelessly advocated for him, believing that true growth lies in learning from the world's best. It was through his efforts that Dr. Meyerson, a world-renowned authority in foot and ankle surgery, was invited to Pakistan. Under the direct supervision of this global expert, that boy received a level of training he had never imagined possible through foot and ankle steps to walk humanitarian programs, and later through augmented reality virtual learning program. He then even got the opportunity to go to US and get a fellowship. That boy not only gained surgical expertise but also evolved into a mentor himself. He is now the president of Pakistan Foot and Ankle Forum, a faculty at Steps to Walk, and Baltimore Limb Deformity Course, USA. His designed surgical devices are being used globally, fully committed to training and inspiring others. Today, that boy sits in front of you speaking about the vital importance of global outreach in medicine, and I can say with full conviction, no one understands its true value deeply than I do. Global outreach matters because there are so many areas around the world who are under-resourced and their surgeons are very eager to learn. There is a famous Chinese proverb, give a man a fish and you would feed him for a day. Teach a man to fish and you can feed him for a lifetime. Through this global outreach, we should go further ahead, as there is a Meyerson's way of thinking that we should aim to create a fishing industry that is only possible through global outreach. Through the global outreach program, a trainee transforms into a lifelong teacher, guiding not only their immediate peers, but also surgeons from distant places. Through the global, he is the best person to take this global outreach further ahead because it is easier to connect with the people around the world. And now, because of the platform that my mentors have provided for me, I am also able to travel across the globe to the areas reaching out where young surgeons who are eager for learning just like I was. And because of my training and the opportunities that have been given to me, I've been traveling across the globe, like in Tanzania, in Philippines, Sri Lanka, everywhere, to teach what I have been taught. Another very important aspect, another very important benefit of global outreach is that the people you train can then globally transfers the knowledge from the global platform to local platforms. And then they can train the surgeons who are around them and then create a chain reaction which can educate the whole country. Like my team and myself in Pakistan, we have this for so many years. We travel across the country to the far remote areas and do live surgery workshops, not only to train the people, but also to help the surgeons, local surgeons, deal with challenging problems. So now I'm going to be talking about the how global outreach can change the lives of people and how it can train the people. So this change has to come one step at a time. You start with training programs. Initially, it can be virtual training programs, online training programs, and then you can go to different centers, conduct workshops, do live surgery workshops over there. And after that, you can start fellowship programs. You can maybe, if you have been to a center long enough and you have been there for a few years, maybe you can develop a center there, which is a fellowship center where you can have a structured learning program where the people from, not only people from the local country, but also people from the different part of the world, from the neighboring countries, can also come to train. And then you can also start community education in that area as well, so for early detection of diseases and different pathologies. But once you start a global outreach program, you have to be very cautious and know the realities of the ground. You have to know the local resources which are available, the language barriers which you're going to encounter when you go there, and you have to know the cultural sensitivities of that area. And in order for you to successfully conduct these programs, it is very important that you engage the local resources, the local hosts into your program. You incorporate them so that they can help you dealing with these problems. And how can you make this program successful is you build a relationship that is based on trust with the local people. You adapt your teaching mechanisms, your teaching methods to the local resources according to the local demand. And continuous mentorship is very important. You cannot just go to a center once and then you feel that you have done your job. You have to come back again. And then once you have concluded your course, you have to stay in contact with them on using social media, anything. You have to stay in contact with them so that whenever they encounter a problem, they don't feel that they are left out. They feel that that supervision is available to them at any time. So that was my journey about how global outreach helped me, and how, in my opinion, global outreach can help so many people, so many surgeons who are eager to learn in far outreach areas of the world. Thank you very much.
Awesome. Thank you very much. All right. I think I have Shuyan's slides up.
Okay, great. Thank you. Very nice talk, Dr. Saad. Saad and Chris, we work together a lot, and we have been on a few programs together. So I'm going to introduce our organization. Next slide, please. So here's our mission, as I said just now. So our goal is to deliver care, specialized care in foot and ankle to the regions that need us. There's a need. And also in the meantime, we realize that education is more important. Next slide, please. We can keep moving. And here's where in the world we are working. And you can see our footprints. This map was from 2 years ago, and now we have footprints in more countries, almost in different continents. Okay, so next slide. As a foot and ankle surgeon, we are colleagues, and we all know correcting deformities seem to be very interesting, challenging, and satisfying. If you see a severe deformity, we think about, oh, how am I going to correct it? And what are we going to do? Then you think about different steps. Next slide. And we also think when we are on humanitarian work or mission, we are doing this, we think about, okay, our work is very important. Correct deformity is the way to serve a community. Next slide. And here's some examples. This is one child we treated with Saad together in Pakistan. That is before severe calcaneus valgus foot from spina bifida. And you can click on the other video. The second one on the far right.
It is not.
Okay, anyway, that is in a few years later, and after the boy is bigger and his foot is more straight and he's able to walk more properly, and his foot functions better. Let's move on to the next one. Here's another child under correct clubfoot deformity. We can keep going. We treated in Uruguay a few years ago. Next slide. And here's another child we treated for severe hallux virus. And actually, that was a polydactyly, and the big toe was removed, but it caused severe hallux virus. And so we treated a few years ago. Next slide. And you can see the work is very satisfying. Here's the spectrum of the deformity we treat: severe varus, equinus, severe valgus. And you can see here rock bottom deformity, congenital deformity, deformity from trauma, deformity from neuromuscular disorders. And then we begin to realize our ability is very limited as a surgeon. Despite how much you can do, you are only just a single person. And as a group also, and your time, your energy, everything is limited. Then we realize we need to do education. It's not just like we go out there, we go to a country, we do surgery, we come back, and then we can help the population. Next slide. So as I said, you need to teach in order to, so through teaching, and we just to can deliver our knowledge and to make our power or our help more significant. Next slide. So why is our work necessary? Just now, Dr. Jonathon gave us a summary of the medical resources, how it is lack in rural areas. Actually, I want to say that it is also happening in the United States. It's not like equally available, and in many states and here in this country, there's still lack of education, lack of care. And also, of course, you understand the more rural area we go, and the more need there is for us to help them. And also in some countries, like well-developed countries, and the advanced care is available in private services. Also in this country, in public services, and people have to wait for years to get treated. Next slide. So that is why we need to deliver education. Next slide. So you all know this saying, you can give a man a fish and that only feed him for a meal. But slide, if you teach him fishing and he can feed himself the whole life. Next slide. So let's revisit our mission. Next, click. Let's advance. So we deliver surgical care, and in the meantime, we do education. That is the whole purpose of our organization. The structure of our volunteer team, we currently have about 200 volunteers in our pool, but we have about 80 active volunteers. They repeatedly come back once they are on a program, and they feel like so the program is very satisfying, and they enjoy doing this, and repeatedly ask us, can we go back, and can we go back work with you? And so we usually take 4 volunteers faculty, 2 senior faculty and 2 junior faculty. And then next slide. we have to have local leadership support from the local society, from the local hospital, and from the local team. And we cannot assume we can do everything without their support. And also we cannot assume we know better than they do. Actually, they are superb surgeons. What they need is some experience in foot and ankle, and also they are the people taking care of the patients. Next slide. After the surgery, here's a child, and we did the surgery, just a routine care, post-operative follow-up, and particularly if there's a complication like in this photo. Next slide. So Dr. Jonathon already went through how we teach during our weekly program. The first day we teaching, we have conferences, we do lectures, and next slide. According to the need, we choose our topic. So in some countries, they want to hear more about trauma. In some countries, they want to hear more about deformity correction, particularly congenital deformities. So we adapt our schedule to their need. So the second day is a live clinic. We examine patients. And very important is the support from the local team. From months ahead of the time, they examine patients. They see hundreds of patients. And from them, they select challenging cases. And also, they need to balance it. You need to combine it. It's a combination with some basic teaching and advanced teaching. So they select about 40 patients for us to see. It's not, we have for the program, they send us slides of the patient's pre-op X-rays, CT scans, clinical examination. For this day, second day, it's not for the faculty to know the patient. It's mainly for teaching. We usually include about 30 to 40 local surgeons, orthopedic surgeons, to be involved in the program. And so we examine the patients, we discuss with them what they think, what will be a better plan for the patients. You need to also think about the patient's background, how far away they traveled here to get to the service. If they are able after surgery, if they are able to come back for routine follow-up, for all many of the time we need to do one stage surgery, and once it's done. They cannot come back repeatedly. So that is the second day. Third day, let's move on. So for day 3 and day 4, from day 2, among those 40 patients, we select about 15 to 20 cases. That depends also on the OR availability. And in most of the countries, we have 2 rooms going on. So as you remember, we have 4 faculties. So we have two faculty working in one room, and the other 2 surgeons working in the other room. And also sometimes we have local leaderships joining us, and in between surgeries, they sometimes said they are comfortable with doing one surgery here and one surgery there. So from those 2 rooms, it's back to back, and we have live video. To begin with, we have the heavy camera, we have the cord connected to the conference room, and now with the advancement in technology, we can just do it from a cell phone and use any like a video, like a Zoom link. And so our participants, they can sit in the conference room, watch the surgeries, and in the meantime they ask questions. You can see on the far top right, that is Chris, and I think he was in Poland. He was in the surgery in the OR room. He was also answering questions and interpreting what he was doing. In the bottom 2 images, that was in Pakistan, you can see that is Saad's program, and you can see Mark there explaining after surgery, and after he finishes in one room, and the camera will switch to the other OR room, and Mark walked into the conference room and talked with the participants, addressed their concerns, questions. Next one. So move on to day 5, that is the last day. It depends on the availability of fresh cadavers. In some countries we can do it, but it's very expensive. And also it's we really feel grateful to the industries. Without their support, we are not able to do anything. You can see Emilio from Chile in one photo. I think we did it in some country in South America, and also one photo is from China. If we don't have availability or access to cadavers, so we turn that day to case discussion. So our participants, our surgeons, local surgeons, can bring their cases and for discuss, share their experience. And also we use this day, as Dr. Jonathon said, for reflection. What we have done, what we did during the day, particularly in the OR room, and what could be done differently. Also, we use this day to go on the ward to see the patients we operated on during the previous 2 days. Next slide, please. So here's the structure of how we do our education. We deliver education, but as you all know, it's very limited, only 5 days. In order to make it sustainable, we need to keep it like we return. One way is we return regularly, routinely to a country or a region, a city, a hospital every year. So if you look at our every yearly program, is almost, it repeats itself. And we go back to that country almost at the same time, because that is a time according to their schedule, and most time we go back to the same hospital. And in the meantime, another way to do it is to do online education. Dr. Saad already shared with you the WhatsApp group. For every program, we set up a WhatsApp chat group. To begin with, it was only for the faculty to prepare with the local host. We prepare the meeting, and once the program is on, we just add all the participants, local surgeons, including their trainees, residents, fellows, and sometimes we include their physical therapists and nurses. So from there, the group becomes like permanent, and you can see those group are very active in Pakistan, in India, in South America, in Africa. They constantly we get consult cases, x-rays uploaded to the group. What do you think? Or I did this, and here's some I regret, and I think it could be done differently. What do you think? So that it is just a sustainable and continuous education. And so ultimately, we want to help people and around the world to improve care. Next slide.
You want your sword to come to that point, and then you just crack it. There you go.
Yeah, we can. Yeah. So here's, in addition to our on-the-ground education, we also have our telemedicine program. So we partner with another nonprofit organization, and we use these smart glasses, just like Google glasses. And you can see there in the top left photo that Dr. Saad was wearing the glasses, and he was doing a deformity correction. And here in the rest 3 images, and Mark was in the US, in Denver, sitting in front of his tablet, and use just white paper as a background. And you can guide the surgeon through the whole surgery and how to do the osteotomy. And you can exactly put your paper clip there where you need to do the cut. So we have been using this very successfully in different countries, in Argentina, in Pakistan, I think also in Sri Lanka, and our pediatric group. And I think that was Maurice Bochard from Toronto, and she was also on our medical board. She trained a senior surgeon, and they went through the whole Ponseti method, how to treat clubfoot. Next slide, please. So, and also we learned what we have learned, that we must learn how to do more than with less. And with limited resources, we don't have, sometimes we don't have the ideal implants, the plate, nail, or the screws, and sometimes we just fix it with key wire. And it also depends on the age of the patient. In children, most of the time we just fix it with key wires, and the result is quite good. Next one. As also mentioned, we also need to learn to correct the deformity in one stage. I will give you an example. Dr. Saad is an expert using external fixator, the Elizarov. But on these programs, we cannot do it because patients, they travel hundreds of miles. And in Namibia, we saw people, like patients travel 1,000 kilometers to us and for treatment. It's difficult for them to arrange the state like they came there with in the state ambulance or bus, so it's difficult for them to come for treatment. And there's no way for us to have staged surgery. Another example, like a Ponseti treatment, and we rarely do it. We teach the local doctor how to do it, but on our trip, 1 week program, it's harder to do it. Next slide. Here's you saw the girl. Here's a foot, severe syndromic problem, neuromuscular deformity, and the severe calcaneus valgus. The foot is so unstable. So if the girl were here in one of the big cities programs, one of the big centers, you would think about treat it with balance the muscles and then correct the realign the foot. However, next slide. We cannot do that on our mission. So we did TTC arthrodesis for her. Next slide. Now here she is, bilateral TTC. She also has or had hip problems. And so she's walking a few months after the surgery. Next slide. Here's another young man after surgery. It's humbling and satisfying for us to see the result of our work. And that is why our volunteers, once they went on one program with us, they want to come back again. Next slide. Because, and you are actively involved with the potential to change someone's life, maybe a little bit, not the whole thing, but it's very satisfying. They can before the surgery, they could not wear a proper shoe, like this severe clubfoot, Kivavirus equinus. There's no way for her to put a shoe on. Sometimes they put a sandal or a very soft shoe. And after surgery, they can wear a sneaker. Next slide. So here's another child. I think that was Dr. Saad's patient before surgery. Next slide. And after surgery, if you can play the video. The feet look beautiful. You can balance, as I said, you can balance the foot, you can balance the muscle, you can realign the foot, and sometimes because there are neuromuscular deformities, you cannot improve the strength of the muscles. So this child has to wear braces. Next slide. So here's our medical board, and so many familiar faces, and you can see they are from different countries. They are leaders in their region. So and I hope this talk will be helpful for you to understand what we do. And here's our website. Welcome to visit our website. I must say our website is a bit behind all the work we really do, and Chris knows well about it. And welcome to join us. Thank you.
Thank you very much. If someone were interested in participating in a program or learning more about the organization, what would you recommend?
I'm sorry. Go that I was reading a note. Sorry. Someone is interested in participating in our program. Yeah. So you can go to our website, and a very easy way to reach out to us is info@stepstowalk.org. That is our website link. Info at our use our link and just write to us. And we have a very proper format of selecting volunteers. So you need to, once you are there, you need to go to our website, go to the page and want to be a volunteer, and you will see the forms, and fill out the forms, please include your CV and including your talk list, because I know of many colleagues, they are superb surgeons, maybe they are not comfortable with teaching, and so we need to see and your talks and what you can teach, and then we will invite you to come with us on one program and see how is it going, and then gradually, and then we will in the future programs, and we will include the volunteer.
Awesome. Dr. Saad, what what role should local surgeons and healthcare leaders play in setting the agenda for these international educational efforts?
Because in these underdeveloped part of the world, because most of the learning that people here can get is from outside. So it's very important for people who do have the knowledge to get involved in such programs. And once they do acquire the knowledge, they have to transfer it to the local population. So what I've been doing, like I do about 5 to 6 live surgery courses in Pakistan in 1 year. So it's very important. I feel it's my compulsion, it's my duty that I have to go there, teach the local surgeons, help them in dealing with complex problems. So I think this is very important to transfer the global knowledge to local knowledge in a local platform.
And how receptive are the local surgeons?
They were initially, like in Pakistan, when Mark came, I've told this so many times, foot and ankle was basic ankle fixations, and then for deformity it was either triple fusion or a pan-talar fusion. That was it. That was the whole foot and ankle. But once the Mark started a chain reaction in Pakistan, and because of the help of social media, we have been able to show the people what we are doing right now. So it's a very they're very receptive, they're eager to learn, and usually filling out the slots is never a problem. Whenever we're going there, I'm like right now 3 or 4 of my future programs are already booked. So they're very receptive, they want you to come. So there's so patients with complex problems are waiting for me there. So when I'm going to go there, I'll be operating. So it's very good. I've told Mark so many times that he has started a chain reaction in Pakistan in foot and ankle learning.
That's awesome. So for both of you, looking ahead, what innovations we saw Mark there doing some telemedicine, but in terms of technology or curriculum or partnerships, what do you think is going to transform global surgical education, foot and ankle care the most?
In my opinion, what I've discussed as well, once we have been to a center for a couple of times, then we need to start a fellowship program. So from where a center where there's more structured learning, from where people can come to that center, do a 6 months or a 1 year fellowship. So that will, I think, take the educating the local people to a next level.
I totally agree with Dr. Saad. I think technology-wise, I cannot think about others, but I think we can structure how we teach. Yeah, as Saad said, we don't just teach individual surgeons in an area, and we also want them to go back to their hospital, to their community. They can teach their trainees and also surgeons from their area. I think another way is I want to address the teaching, like like Chris, you have been doing great. You took your residence fellows with you on the programs. We have funding grant from J&J to support us to take residents and fellows from here or from overseas to a specific program with us. And now with this global health or service program in different medical universities, I just saw a note in the chat group and how medical graduate or how medical school students can participate in our programs. I think it's a great idea for them to see the real world, and also I know they can help us if they have some. They can speak a second language, like in South America. We need to speak Spanish, so we choose our faculty, and also depending on language, that is one criteria. In other countries, we have to language or we need translators. Thank you.
Awesome. I can only imagine that, with AI being able to translate things pretty efficiently and effectively, almost instantaneous now, that language is not going to be a barrier much too longer.
That's a good point. Very good point. Now, also I think about I have had this thought for a while, and I have been working on it. And so that is how to connect our U.S. medical school students with international medical school students. And you don't have to be with us on a program and to operate and to treat like one specific patient. If you can help your peers from other countries, that will also be great contribution.
Awesome. Well, I think we'll let the next team gear up and load up their talks and things like that. I want to thank everyone so very much for allowing us to talk about Steps to Walk today, about how it's affected surgeons across the world, how it's affected patients, in helping their ability to walk and have meaningful, pain-free lives. Again, there is information on how to join the organization in the chat group. Please consider it. I'm happy to answer any questions offline. I'm at cgross144@gmail.com. Thank you, Dr. Saad. Thank you, Shuyan. Thank you so much.
Thank you, Chris.
Thank you, guys. Thank you so much for finishing it well in time and sparing some minutes as well. We in India also have started with Steps to events from last 2 years, and we have had a fantastic experience. And we are still waiting for Shuyan to come to India. So thank you very much. Have a great evening.
Thank you. Bye-bye.
Bye.
Thank you so much. Take care.